Thank you very much, Professor Hussien. Good morning, everybody. I am delighted and grateful for inviting me to this very fruitful meeting. By way of starting, let me tell you that the survivors of cancer are increasing worldwide. This is an analysis that shows the cumulative death rate observed versus expected in cancer survivors. What happens is that those who survive childhood cancer, as a matter of fact, happen to die much more than expected. A cancer survivor is in the middle of a myriad of ordeals. It's not only the pain, fatigue, it's not only the heart failure, it's not the arrhythmia, it's not the drug interactions. All this adds to factors like role disruption, social changes, and inability to earn income. And these factors all intervene with the quality of life of these patients. Since cancer diagnosis, patients are either defined as a low risk of developing long-term late complications, or at a moderate risk, or at a high risk. And these groups are classified according to the circumstances of the individual cancer. For example, those who just need surgery, they don't need no alkylating agents, no radiotherapy. These patients have a low risk of recurrence, and these patients have mild or no persistent toxicity of therapy. Followed by a group who have to use alkylating agents and radiotherapy, or those with autologous stem cell transplantation. And the most risky, of course, are those using high-dose alkylating agents and high-dose radiotherapy, allogenic stem cell transplantation, high risk of recurrence, and multi-organ toxicity of therapy. This classification is intended to group the patients with cancer at the time of diagnosis into a profile that can predict how they are going to behave. This is a study of the medium and long-term risks of specific cardiovascular disease in survivors of different forms of cancer. And this study shows that whereas arrhythmia and heart failure tend to increase or remain the same after cancer cure, the risk of venous thromboembolism tends to decrease steeply after cancer cure. So in a matter of 6 months after treatment, the risk of venous thromboembolism diminishes very much, whereas the risk of heart failure or cardiomyopathy continues to increase, as you see in the middle panel, middle upper panel. These observations show that most cancers survivors have increased risk of one or more cardiovascular disease, and the pattern of risk varied by cancer site and by outcome, whether you can produce cure or quiescence or no cure. There is increased risk of venous thromboembolism for most cancers, but this diminishes quickly after cure. Increased risk of heart failure or cardiomyopathy in survivors of nearly half the cancers, which continues to increase after cure. Risk of other cardiovascular disease outcomes, including coronary artery disease and stroke, were elevated. And association between cancer and cardiovascular disease is not just enough to explain by shared risk factors. The cardiovascular characteristics of a cancer survivor in general are: number one, there is increased prevalence of conventional cardiovascular risk factors. These patients tend to have more hypertension, more dyslipidemia, and believe it or not, more smoking. The incidence of a second primary neoplasm is always there. Not just because the patient is prone, but because the treatment which we use and which is essentially immunosuppressive treatment results in reduced immune surveillance and increases the chance of a second cancer. Also, the incidence of viral myocarditis from prolonged immune suppression, hypertension, VEGF inhibitors and ordinary risk factors, pulmonary hypertension, either thromboembolic or lung toxicity or COPD, and of course the incidence of deep vein thrombosis and pulmonary embolism. Finally, the late cardiac toxicity of current treatment. At the beginning of treatment, we should judge the methods we can use for primary prevention. For example, we know now that there are methods to reduce the cardiotoxicity of anthracycline during the administration. We know that there are drugs like intracellular iron chelators, dextrazoxane, for example, which also reduce the cardiotoxic effect of anthracyclines. And we know that for a subgroup of patients who start to show rising troponin and NT-proBNP, prophylactic use of an ACE inhibitor and beta blocker, some trials examined the prophylactic use of carvedilol and enalapril and showed that the long-term myocyte toxicity is reduced in these patients. Later on, we try to intervene at the level of subclinical damage, and this is difficult to decide, of course, and finally, we treat a cardiovascular event when it occurs. The baseline risk factors for cardiotoxicity are, first of all, concurrent myocardial disease, of course. The second is demographic and other cardiovascular risk factors. For example, the pediatric population and the more older population. Family history of premature coronary artery disease. The presence of pre-existing arterial hypertension, diabetes, or hypercholesterolemia. Some lifestyle risk factors like smoking, high alcohol intake, obesity, and sedentary habits. The late effects of chest radiation poses another important risk. Valve disease is common in these patients. Particularly, you'll find aortic valve disease and mitral valve disease. The anterior leaflet is more damaged usually than the posterior leaflet. Atherosclerosis and pericardial disease, whether acute pericarditis early after radiation, chronic pericarditis, effusion, or constrictive pericarditis. Myocardial and endocardial disease, which occurs as a result of radiation, and conduction defects. Conduction defects including particularly bundle branch block and or complete AV block. Atherosclerosis is usually characterized by being a proximal coronary artery disease. Hypertension is another problem which can be caused by cancer treatment. There is an imbalance between the vasoconstrictor and vasodilator mechanisms, together with endothelial dysfunction, glomerular dysfunction, and capillary rarefaction, particularly with VEGF inhibitors. Hypertension with VEGF inhibitors is a particular group which is increasing, requires standardized blood pressure measurement, history, physical examination, and using this information to determine the appropriate intensity of monitoring and targeting. To monitor during treatment, actively monitor blood pressure, and intervene at the standard levels for intervention in a non-cancer patient. The management, many antihypertensive drugs can be used in these patients, and the blood pressure elevations have to be managed just more aggressively to avoid complications, paying attention to agent selection, dose, and consider the discontinuation or dose reduction of the VEGF inhibitors if possible, particularly if the diastolic blood pressure is not controlled by antihypertensive medication. The exact pathophysiology of VEGF-induced hypertension is strikingly similar to what happens in preeclampsia. As a matter of fact, proteinuria occurs in these patients and a preeclampsia-like syndrome has been developed. Coronary artery disease is associated with 4 classes of therapy. Fluorouracil, and that situation, the disease is dominantly vasospastic. Platinum compounds, and like carboplatin, and the disease in these conditions is dominantly thrombotic, not vasospastic. VEGF inhibitors, the disease is distal, and it's associated with more capillary rarefaction, and radiotherapy, the disease is proximal and often multivessel. Atrial fibrillation is the third most important thing that can complicate cancer therapy. Cancer surgery itself can precipitate atrial fibrillation, lung resection, for example, colonic resection, chemotherapy, targeted therapy, cancer-related comorbidities like paraneoplastic syndromes, inflammation induces atrial fibrillation, and shared risk factors between cancer and heart disease. All these factors are associated with increased risk of atrial fibrillation. Atrial fibrillation in a patient with cancer is a particularly important condition, and there are many cancer drugs, as you can see, both targeted and non-targeted therapy that can precipitate or increase the incidence of atrial fibrillation. One has to be aware of these, usually not memorizing them by heart, but one has to consult directories or tables when the situation is about to administer any one of these drugs. What should cardiologists know about atrial fibrillation? The differences are basically in 2 things that we need to remember. First of all, cancer-related high bleeding risk, such as intracranial tumor, hematologic malignancy, coagulation defects, etc., have to be observed. Severe metastatic disease, severe hepatic disease as well, probably these patients are at a very high risk and they shouldn't be receiving anticoagulation. The other thing is direct oral anticoagulants have been proved as effective and safe in cancer and easier to control than warfarin by virtue of less interaction with cancer medications. Hodgkin lymphoma is a particular condition which is associated with high survivorship these days. And a cardiovascular disease in survivors of Hodgkin lymphoma, this is the most common non-malignant cause of death in long-term survival. Those who survive Hodgkin are most likely to die from cardiovascular disease. The treatment of Hodgkin lymphoma itself is associated with cardiovascular disease, valvular disease, particularly from irradiation, pericardial disease, arrhythmia, cardiomyopathy, and a peripheral artery disease. So we can find a patient who survived Hodgkin lymphoma that affected him in early adult life, and then he continues very successfully in his career and life until he is in his late 50s, where he can start to develop either coronary artery disease or severe valvular heart disease, or both. There is increased cardiovascular risk that emerges soon after the completion of treatment and continues to be elevated, particularly if the combined use of anthracycline and irradiation are employed. Pre-existing heart disease, and this is important, pre-existing heart disease is the most significant predictor of post-Hodgkin lymphoma therapy cardiac complications. Other risk factors are chemotherapy and radiotherapy and traditional cardiac risk factors. The risk of non-coronary atherosclerotic disease is increased in patients who underwent radiotherapy to the neck, and those patients can develop not only coronary artery disease but as well carotid artery disease. Regarding the diagnostic tools of myocardial toxicity, unfortunately, currently, we are still dependent on the nuclear cardiac imaging, the MAGA, and the 3D echocardiography. Emerging techniques, including the measurement and follow-up of the global longitudinal strain, cardiac magnetic resonance, and cardiac biomarkers. The cardiac biomarkers are very sensitive. The problem is sometimes we don't know what to do with the early data. When the left ventricle looks fine, ejection fraction is not going down, but the cardiac troponin and the NT-proBNP are rising, and the patient still has more sessions of chemotherapy to complete. In this case, you are in a situation of deciding whether the risk is warranted, whether you should administer prophylactic ACE inhibitor and beta blocker, or whether the risk is not warranted because the value is low. Myocardial toxicity in cancer survivors, once it occurs, it has to be handled much more like a conventional heart failure. And the reason why is not because they are the same, but because cancer survivors do not constitute a significant fraction of heart failure trial patients when you look at it. Symptomatic left ventricular failure is treated as ordinary heart failure. Monitoring the left ventricular ejection fraction and systolic dimension, global longitudinal strain may help to identify early LV dysfunction, and these patients probably benefit from a combination of ACE inhibitor and beta blocker based on small patient series rather than large randomized trials. Heart failure with preserved ejection fraction, usually a late effect of radiotherapy, is handled as heart failure with preserved ejection fraction otherwise. This is one example I want to show you. This is a real patient in progress. What you see here is this patient had breast cancer, and with treatment you can see that her left ventricular ejection fraction is going down, and the left ventricular and diastolic dimension is going up until ACE inhibitor is initiated here, and you find that the situation starts to improve again. One should do this at a much earlier stage and not wait too late. My messages are: one, as cancer survivorship increased, the incidence of cardiovascular disease appeared as a major risk to survivors. Two, the commonest cause of death with cancer cure on long-term remission is cardiovascular disease. Most obvious in survivors of childhood cancer. The whole spectrum of cardiovascular disease is increased, including hypertension, left ventricular dysfunction, valve disease, pulmonary arterial hypertension, pericardial disease, AF, venous thromboembolism. Three, cardiovascular disease contributes to disruption of the psychosocial role and the financial support of cancer survivors. Four, the major causes of cardiovascular disease are therapy-related adverse events and increased prevalence of traditional risk factors. Of course, the more pronounced predictor is pre-existing heart disease as well. Finally, cancer survivors do not constitute a significant portion of cardiovascular trial patients, and so the treatment is tailored to individual needs. Thank you.